We're delighted to have you join us for another session. My name is Jackie Sable. I'm a member of the ECHO team, and I'll be facilitating today's session. A few quick announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you're speaking. If you're dialing in from a phone, you can use *6 to mute or unmute. And if you are on a device using the ECHO app, you can click on the microphone on the bottom left-hand corner of your screen. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible during the session, but we will follow up with any unanswered questions after the session. If you have suggestions for future COVID-19 ECHO topics, please share via the chat tool, or you can email us at echo@psu.edu. Please remember that no personally identifiable information is allowed when we're discussing cases. We are recording these sessions, and we will share the recording and other material after the session. In the spirit of all teach, all learn, we'll be on a first name basis during the sessions. For those of you who are new to ECHO, our ECHO sessions always begin with a brief lecture, followed by a case discussion. Cases include a question or challenge, and we encourage you to submit cases which can be related to patients, preparedness policy, or whatever challenge you'd like to generate discussion around. The link to submit cases is always included in our follow-up emails. For today's session, Dr. Stephen Handler will discuss the use of telehealth in long-term care during the pandemic, and Dr. Amy Westcott will be sharing a patient case. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State online, and they help to field questions. But remember, this is an all teach, all learn environment, so feel free to share both questions and answers. We'll pause between the brief lecture and the case to address any questions that you may have. And with that, I am going to turn things over to Stephen for our brief lecture.
Great, and good morning, everybody. I appreciate the opportunity to do this session. This is the first Project ECHO that I've been involved with, but hopefully not the last. I appreciate the team working together with me real quick. This is an edit or a slice of a talk that we gave for the California Long-Term Care Medicine Association, associated with the AMDA, or the Society for Post-Acute and Long-Term Care. And really what I'd like to talk briefly about and then field questions, because there's been a lot of change recently in telehealth policy and approach in the post-acute and long-term care setting is really how to better use telehealth and approaches similar to that. So on the next slide, please, or I can do that. You told me, hang on, there we go. If you want we worked on this guide. This is if we had the normal amount of time to think about telemedicine, to implement telemedicine, to use telemedicine. And so this guide was put together in conjunction with AMDA, sponsored primarily by West Health. And you can get the guide in its entirety by clicking on this link or writing it down or asking for it later. And it's very detailed about how to start up telemedicine. However, things have changed quite substantially. On the next slide here, what we're going to talk really about is how do we manage and how can we use telemedicine as a tool, but that's just one piece of the puzzle. So I don't want to overly rely or fit towards the technology. But first we have to start with what's the problem? You know, what are we seeing, boots on the ground? I know at least locally here in the Pittsburgh area, we have a number of nursing homes that are now starting to see a lot of cases of COVID-19. And we've been in communication through a variety of grants and just collaboration. So let's go through the next slides and figure this out together. So a really important article, and it seems like years ago, came out on March 27th, and it really talked about rather signs and symptoms of COVID-19 in skilled nursing facilities. So we're going to just jump right into this clinical setting. And the main take-home points are here to the left, and they're a little bit concerning. So symptom-based screening may fail to identify infections. A lot to do with older adults. They may not present typically with regard to fever, even cough, or they may have atypical presentations. And so we have to keep in mind that, and in this article goes through effectively what were the signs and symptoms at day 1, and then 7 days later, and the evolution. And so it's also important to note that symptom-based assessment is more difficult and more challenging in those that may have cognitive impairment. I think we all realize that, but it's important to note that. And although we always talk about the concept of infection prevention and control, I think it's more challenging in nursing homes that as a clinical setting with relatively low clinical capabilities and resources. And so, you know, the early things happen early, which was visitor restriction, screening, but we realize also that screening just doesn't work all the time. So one of the ideas that we're going to talk about and why we're perhaps interested in this talk today is really how can telehealth be used as a tool to assist in this, this approach. So on the next slide, what we started to think about, believe it or not, the very first thing was the concept of forward triage, which you may have seen in the literature, and we'll talk more about it during this talk here. So the concept of forward triage is, can we assess a patient or resident in place without the need for bringing someone into the ED or hospital? The purpose of doing that would be to reduce the exposure. It would be to really treat and be consistent with care plan goals and directives from the resident. And then more importantly, or however you want to look at it, is this concept, as you know, flattening the curve and really reducing the impact on the central hospital systems with regard to a surge, right? And so if you can treat people in place, well, let's do that. And so we know that this model, even before COVID, was coming out through the ET3 model, which is basically paramedicine and others. How could we use these forward providers to help us with that? And a little more detail on the next slide here is that, you know, the benefits of forward triage and going through some specifics of that, it could extend the practice of paramedicine, provide real-time decision support. And how that works, and let me go through the use case, is that if, for example, someone calls and has signs or symptoms that are concerning, once again, we may not know all of the signs and symptoms and how they align with older adults, but what we do is we can deploy a telepresenter who in this model would be a paramedic. Paramedic would go and has training already on how to go and assess a resident or a patient, take a specimen, you know, a swab at this point, right, to determine if there's COVID or now some of the point of care tests that we know about. And then with telemedicine as the bridge, go between that paramedic and the central command through an ED doctor and have a real-time discussion and go through an algorithm. And then if transport is required, to also ensure that the transport is to the most appropriate location, the facility, hospital, ED, or whatever that has capacity to manage the person who is being evaluated. So that's really the high-level overview as to the value of this, and it can reduce the risk to other patients, improve patient-provider outcomes and satisfaction. We went live with this forward triage approach throughout the city of Pittsburgh EMS. We outfitted them with technology to connect their pre-existing iPads through a FirstNet cellular modem back to command and control. And I can certainly talk more about that if people are interested. So that's something that we're actually doing right now. Can't tell you the outcomes, but it's something we're doing. And then the other thing that is useful certainly is that if a facility already has telemedicine, and we'll go through the use case where they don't have telemedicine, but if they have telemedicine, and this is an example of a telemedicine cart, it could provide a single number or point of entry for consult requests. And what's really important to note is that the, especially in this time, and I felt this for a long time, you know, already, that the nurse is your primary customer in the nursing home. The nurse is the person who's kind of decoding what's going on and reaching out for help. And so with telemedicine, you can have the single point of entry, you can have qualified, responsive, knowledgeable, and dedicated provider workforce working remotely, of course. And they can complete and share this documentation in a timely manner when they're done. I can go through that if you'd like. And then use a standardized approach. And I'm going to share with you at the end an approach that is an evolution, and you can have access to it today, realizing that it is in evolution and being updated all the time. And then it could coordinate or flip back to that prior slide that once telemedicine is done, and if there is a need to escalate care, you then could coordinate that better with EMS and central command for transport purposes. So that's how it could all fit together with regard to the pieces of the puzzle. And what's, I think, essential and depends on how you look at this is that now more than ever, understanding people's care plan goals and using a framework for that. And I'm not promoting any particular approach specifically, but what I am trying to do is increase awareness that unfortunately, if you look at some of the articles in JAMA and then also other articles that focus on outcomes, those that are transported from nursing homes and that reach the hospital, they go on the ventilator, they don't come off a ventilator. It is a uniformly deadly disease with that regard. So what is essential and what we're promoting is for those facilities that don't have COVID, please consider doing and ensuring that you have the appropriate care plan goals documented now. And then if, for example, once it does hit the nursing home, because I think it will unfortunately uniformly hit most, is then another, to use this as guidance rather than just automatically sending somebody in, realizing, of course, that the outcomes are particularly bad for this population. So this is some framework and approaches. Once again, whatever you use is great, but please consider having these conversations, which are difficult, of course. And this is perhaps a bit difficult to read, and this will be in the QR code at the end that we distribute, but this is effectively a triage approach where you start in the upper left-hand corner and you have typical signs and symptoms. We use a lower temperature threshold of 99 or 37.2 centigrade for thinking about someone having COVID. And I put that because if you look at the green boxes to the right, the initial and follow-up, these are people that are tested COVID positive. And it talks about the typical signs and symptoms where you have, it's very interesting, cough, shortness of breath, and fever are relatively low, cough being the most prominent at 30%. But over time, there's an evolution and people develop a fever over time in particular. So it's a little scary because a lot of the symptoms that you look at here, both initial and follow-up, are very much like it could be conflated for seasonal allergies or the flu, okay, which is an important distinction. Pneumonia, of course, or other pulmonary concerns. And so what we have here is if you're concerned, you do that initial management in this box here, which is placing a surgical mask on the resident, maintain the resident and their roommate in the room unless you can relocate both, which is probably not going to happen. Place in standard contact droplet and airborne isolation. We're concerned more than ever about all three mechanisms of transmission, and then use an N95 gown, et cetera. And the reality is, when you have it, I think what we're seeing is that PPE is difficult to get. And then this box down here is really your triage. If they're stable and or their advanced directive doesn't support transfer, what you can consider doing. This is not always do, these are considerations. And if they're unstable and an advanced directive supports transfer, how to notify EMSnet for a triage approach. I'm happy to go through the diagnostic approaches, which include, still at this point, looking for co-infection with influenza and COVID, of course, and consider a traditional workup for fever or for sepsis, et cetera. A stat chest x-ray is useful and some basic labs, although other labs have been promoted as well. However, the cost and or availability may limit their utility in this clinical setting. So let's say you wanted to do telemedicine because you wanted to, basically employ this pathway, this approach, et cetera, or you want to start it up or you want to basically use it because you have it. So once again, this is coming from that guide that we developed with West Health about a year ago. And I'm going to go through fairly briefly some examples, consents, tools, and workflow for here. So the key to this is if you're going to have a remote workforce, you need a telepresenter. And I'm pretty sure you guys already know what a telepresenter is, but just to make sure we're level set it, that's going to be the person who's going to operate the equipment, who's going to control the room and the resident, who's going to try and help you maintain HIPAA compliance, who's going to, do the examination, et cetera. And, it has not been, at least that I've seen, and the government has not said who is or what the requirements are for telepresenters, but we believe that many people can be telepresenters, including, of course, the EMTs where we started, but nurses certainly, and that's not CANs, but CNAs, it always autocorrects, and medical assistants, and they can facilitate the exchange of information between that originating site at the nursing home and the distal site where the provider is located. So the key to this is equipment, and now more than ever, it has become very difficult to get new equipment right now. Even those of you around may say, wow, I can't even get a webcam and I ordered it, or a computer. It has become very hard because not only, we have a very large remote workforce, all trying to scramble to make their home offices as best they can, but that also, of course, impacts healthcare when the supply and demand are not well matched, along with many of the hardware and software solutions are coming from China, at least, which was, the epicenter for this, as far as we understand. So the key to this is first identifying where in the facility you'll be using telehealth. In our traditional approaches, we do it in the room. And especially now more than ever, if you can't have a mobile diagnostic telemedicine approach, probably doesn't make much sense, because if you're taking the nursing home resident and moving from their room and moving them through the hallway to another exam room, well, if it's COVID, guess what you may have done? You may have spread it through the facility. So it's important to be able to do the telemedicine in the place in which the resident is actually located. So that is easier said than done, because the equipment that you might need, even if it's simple tablets to get secure, or now you can use even less secure approaches, given the HIPAA relaxation, at least temporarily, is just having connectivity. Nursing homes oftentimes don't prioritize having very strong bandwidths, or can't, because they're in rural areas and the connectivity isn't very good. So we have a mantra of no connectivity, no consult. So it's very important to really assess the connectivity prior to spending a lot of money, frankly, because if you don't have that, then you could have a fancy card or tablets and it won't work. So it's important. And although it states Wi-Fi here, of course, we know that cellular has become more of an option. So please don't discount that as the opportunity for you to connect your equipment to that distal site provider. So in recognition of the potential importance and utility of telemedicine, CMS has really relaxed a lot of its regulations. And I'm more than happy to go into a lot of this right now for any of those who want to know more about billing and coding in this setting, HIPAA, whatever you want to talk about. Effectively, at a high level, cross-state licensure in most states is allowable now, even if you don't have a license in another state. DEA has been relaxed, and billing and coding has been relaxed very substantially, especially for the nursing home setting, where previously it was fairly restricted to rural settings. One resident can only be seen every 30 days, et cetera. And I'm happy to go over that for those of you who would like to. But technical assistance and vendor selection for doing telemedicine, really, this is on you largely. I can make some suggestions. I don't have any conflicts at this point. And so it's difficult though. So one of my suggestions as a takeaway is use something simple and cheap, getting a tablet. And we'll talk about the software that you can use, including the platform that we're on, despite it having some security issues recently that were brought up that are a little bit concerning, I will admit. But right now it is not, and hopefully they'll fix that. On the next slide, this talks specifically about that. So HIPAA has been relaxed. That doesn't mean you can totally relax. What it means is that use your best approaches, okay? Try to make it HIPAA compliant and secure. If you cannot, then go to alternative approaches, okay? So they're not going to impose penalties, but it's still not good practice to use open facing types of chat approaches and things of that nature. And CMS actually specifies what apps, at least initially, it was allowing versus others that it was not allowing. So other things that have been relaxed is the nursing home audit suspensions and other agencies with regard to inspection and whatnot. Basically, the government is trying rather to make it easier, remove as much of the friction as possible for now. Don't expect that to last forever, but perhaps some of these will stay as is. So If this is important to you, you have to really try and align your needs throughout the entire organization, right? We know how this is a top-down approach. You have to get the administrative buy-in, but in the end, the real people doing this are the frontline nursing staff, primarily, perhaps the CNAs, and everyone needs to believe that this is valuable to them. You have to sell it to them. So you have to identify your needs that, let's say COVID-19 is here, that COVID-19 is best or partially addressed with telehealth. As the workforce diminishes, both the provider workforce and the frontline nursing staff may diminish, and then select and deploy a tool quickly, identify champions. You guys know all this stuff, right? If you've done telemedicine, and build a simple workflow that engages people, but also doesn't stress them too much, right? And then monitor and readjust. So I'm gonna transition now to Amy, unless you want me to answer questions now. You guys tell me how you'd like me to move through this process.
Thank you, Stephen. Yeah, let's open it up to questions. Does anyone have any questions or comments for Stephen before we go into our case? And if anyone is doing anything with telehealth and has other strategies or information to share, please feel free to either put that in the chat or unmute yourself.
Hi, this is Rebecca Steele. I am actually working with UVA Health System, and we're standing up these telehealth services in skilled nursing facilities. And we're really trying to build out a nurse liaison connection so that in addition to have an LIP consult, we are really connecting with those who are doing the work there and supporting them not only through a consultation for patient concerns to LIPs, but also around infection control, PPE preservation, and stewardship. And so I'm curious how you all, or if anyone has built out a nursing component to these types of programs, because I think that's really key here to make sure that not only do two champions know how to use the technology, but that everybody would feel comfortable with it. So that when staffing becomes a concern, you have more than just two people who know how to use it.
That's a great question. I'm coming at this primarily as a physician provider and someone who understands technology. I will say that that is an area my own personal weakness, and we are addressing it at a state level with others that are much more skilled at communication with the frontline nursing staff than I've dedicated my efforts and knowledge to. So for example, the Jewish Healthcare Foundation here that resides in Pittsburgh is working with us at our state level to develop videos and centralize the content. I think what you're doing is wonderful, and I agree that that's a very important part of what we should all be doing. Once again, it's a nursing home for, they call it that for a reason, right? So we have to make sure that we're engaging the frontline nursing staff in particular. So I certainly welcome, and part of this, I suspect, is for us to share. And the only thing good about, frankly, COVID that I understand at this point is that it's a forcing function for us to all share quickly and share best practices, et cetera. So I encourage you at the end, for example, and take a snapshot of the QR code, take a look at that, review it. If you have readily available content that you can plug and chug into that, and you can take mine, we can band together. I think that's the key to this. So I think you're spot on.
Yeah, I think sometimes the nursing piece often gets left out of these telehealth solutions. And I think this is a vital, essential piece that people really need to start to incorporate, because ultimately they are the end users. So we need to be sure that we're including them.
Definitely. And I think I've said that through the talk, even saying they are a primary customer. But what I have not found, I'll be perfectly honest, is a partner in crime, so to speak, on the nursing end as much, who perhaps feels the way you do and perhaps has the skills and interest. So this might be a perfect match to get this out there to help more people.
Absolutely.
Thank you for bringing that up, Rebecca. And I do want to remind everyone that I think Stephen said in the beginning, let's figure this out together. So thank you for bringing that point up. Stephen, there is a question in the chat. I don't know if you can see that.
Yes.
Can you suggest platforms for telehealth?
Sure. Okay, so with regard to platforms, I think that the point I made earlier is that there is a relaxation of HIPAA and the privacy concerns, meaning that you're not going to face a lawsuit. But that doesn't mean you shouldn't do the right thing either, right? And if this was you who was being treated, we want to do the best by the situation. So with regard to platforms, Zoom is great in many ways. Once again, I'm not promoting one over another, only because it allows for, especially in this situation, the ability to involve a family or a team. And adding people on remotely and is really essential. So one of so in terms of answering this question, trying to be platform agnostic, I think an attribute of the platform is good audio and video. And then second, the ability to add on additional family or team members. So, so for example, if you want to have a team meeting and that person may now be working from home because they're in self-isolation, or you want to involve another family member because you want to reflect on the care plan goals, et cetera. So looking at your list, FaceTime is okay, but the problem with FaceTime is it requires both endpoints to have Apple products. And so that could be an issue. So I usually don't recommend that, even though I like Apple. That's just my own bias. Zoom I like, and Skype is okay. I've had a lot of issues. Technically, I don't think it's as robust. Once again, I am not trying to promote one over the other. I also find it more difficult to add on additional team members. However, I think the key to all of this is use what you have. If you have something, just use it. One thing to note is that Zoom offers a free, to anyone who wants to sign up, I think the account is for 40-minute sessions or less. So if you believe that your consult will be 40 minutes or less, you can sign up today, get it and run. That I think differs from Skype perhaps, and its integration of course into Teams and other things like that. So that is still my go-to because it's the easiest to learn and use. But once again, I'm not promoting anything here. I just want to be clear. I just want you guys to get up and running.
Thank you. Other questions or comments? If not, I think I'll ask Erica to bring up the slides again, and Amy can take us through a case, a patient case, and I'm sure we'll have more discussion after that.
Great, thank you for having me. So I know Steve from years ago. So Steve, I'm really grateful that you're able to join us today for this. And my background is in geriatrics and palliative medicine, and I currently am an associate professor at Penn State Health with another role, a hat I wear as the Optum Medical Director. It's an institutional special needs plan, and we cover 7,000 lives in Pennsylvania and Delaware. And we're in about 170 nursing homes. And so we're trying to figure out how do we communicate with families during the COVID-19 pandemic. And as Steve alluded to, it's very building specific and home specific, and how do we support the workforce given what's happening. So the case I have is from a couple of weeks ago when we didn't have COVID in many of our buildings yet. However, we were still trying to limit visits in certain homes based on geographic location, what was happening in their communities. And so one of my homes, we had an 87-year-old woman who was in long-term care, and she was newer to our program. So the nurse practitioner that worked with her knew her for about 2 to 3 months. She had a past medical history of metastatic breast cancer and high blood pressure, CKD, heartburn, and she required opioids for pain related to her metastatic breast cancer. And her symptoms were that she wasn't eating well, and she had lost weight over the past few months. And she was really sore all over. She was uncomfortable. And, you know, the nurse practitioner had developed a good relationship with the power of attorney, who was the niece. Next slide, please. And, you know, some of the medications, just for some background, the opioids she was on, a proton pump inhibitor for her heartburn. She was still on blood pressure medicine and something for constipation, as well as her cancer therapy. And she had PRN uses of medications for nausea, pain, and constipation as well. Next slide, please. So things to know about this woman is that the nurse practitioner got to know the niece and the patient, and they agreed that DNR/DNI was most appropriate. She was losing weight, so they did a trial of mirtazapine, which was not value added. They made sure she wasn't constipated, and that was causing her anorexia and nausea. And the niece was really struggling with changing focus to comfort care as she was declining. And the patient, you know, was leaning towards comfort care, you know, but very close with her niece. And so what happened one day, next slide, please, is, you know, what the situation we ran into is this woman was declining. The building was limiting visitors. And so our nurse practitioner was providing telephonic support. And, you know, what could we do in this situation? And the building was like, you know what, we have iPads, we're ready to do telehealth. So right then and there, the nurse practitioner who had a relationship with the niece was able to do, you know, utilize the telehealth support for this resident. So next slide, please. And what the nurse practitioner found was that, you know, this patient was delirious. She was able to see the patient. They actually used FaceTime, Steve. However, we're using Zoom, and basically whatever the home is able to use is what we're using. They FaceTimed with one of the nurses who was able to be in the room with this member, and she was delirious and dehydrated and clearly in decline. And so when the nurse practitioner was able to call the niece and let her know that she was visually able to see her loved one, it was huge. Because they had already had this relationship, and then the fact that she was able to see her because the niece wasn't able to see her at that time. And then, you know, our nurse practitioners are trained in serious illness conversations and vital talk language, and was able to coach the niece through, you know, comfort care and what that could look like. And the niece agreed to a do not hospitalize order. And a couple of days later, this resident was able to die comfortable in her home. Next slide, please. And so I think with this case, what highlighted to us, we were in real time incorporating telehealth into a building. And, you know, we are doing staff training depending on the building we're in. The buildings are owning what platform we use, and sometimes we're distributing the materials for it. The flexibility with the platform, like Steve talked about, being willing to utilize whichever the building is comfortable with, because they're the end user, the staff in that building, the nursing staff. The most valuable piece we have found in our experience with telehealth is the visual. While it's really cool to be able to get breath sounds and listen to somebody's heart, it really takes a lot of effort for the team in the building to operationalize that. And especially now that we're seeing, you know, in this pandemic, all the PPE and everything that goes into it, it's going to be a real challenge. And so the visual is really the greatest. And even sometimes the visual from outside the room into the room to assess is highly valuable, is what we're finding. And the most success we're seeing is during daytime hours. As you can imagine, that's when we have the most staff in the building and the most flexibility. Some buildings are actually starting to set up a daily call or a 2 times a week call to talk about different residents in the building and review the list of residents and any concerns they have. And then some are calling us only with acute changes in condition, for example, shortness of breath, pain, crisis, things like that. And so we're able to manage in real time. So these are some of the takeaways. Like Steve said, we're all learning this together at the same time. And so I just wanted to share this story with you. Thank you.
Thank you for sharing that, Amy. Stephen, do you have any comments before we open it up to other discussion?
So the main comment that I would like to make is that telemedicine is really a tool. And in this case, this was a great use of the tool to connect family, to basically confirm what we knew should probably happen from a clinical perspective, but allowed closure to take place. And I think a lot of times, if we move and step beyond the nurse as the primary customer, of course, ultimately the family and the resident are, right? They're the people we're serving. In this case, we now switch from the nurse back to the family, the dyad, or whomever was involved in this. And it showed how essential it was for them to reconnect, to bring closure, reduce their anxiety, And even as you saw on the slides, just having someone available, even when they're not physically available, but to guide them through a difficult talk and discussion, to make them DNR, bring closure, and then allow someone to pass peacefully. I think that was critical in this case. And I think, unfortunately, and I agree with Amy certainly, that the additional bells and whistles of peripherals in this time are probably not all that useful. So that's all I'll say. I think this is a perfect use of the technology and using what you had and just getting it done. So it was great.
Yeah, if anyone has done something similar or been able to pull something together with your existing resources, please feel free to share that in the chat, especially platforms that have been successful for you. I'm going to see, are there any comments or questions from our participants before I open it up to a couple of the members of our panel who are also online? All right, well, without putting anybody on the spot, a few members of our panel are here. If any of you have anything additional to add, please feel free to unmute and share your perspective.
I think the key here is to understand where the patient is and to meet them where they're at. You know, I think just like Steve said, figure out where the patient's at and what technology best fits that scenario, especially now that things are a little bit relaxed. But I think sometimes we can overcomplicate these things and really just kind of take a step back and understand what the workflow is and what the need is, and kind of work with the frontline staff and how we can best incorporate these technologies.
Thank you for that. Someone mentioned in the chat that they're using the WhatsApp FaceTime, which is also another great approach. And there's a question, I think is a good question. Does anyone have experience integrating translation services into telehealth?
Hi, good morning. This is Omar. So the translation services, we are kind of trying to find out what's the best solution. Some of the platforms actually have ability to built-in translation services. So as you know, earlier it was mentioned that it's important to be able to add like a third person or a third party or another party in the feed. So it makes sense that if there is an existing translation you know, software or a company or somebody you use, if there is an ability to bring them into that patient and provider conversation, it would be very helpful. I think we at the Penn State are looking into the option, the platform we use. On some of the websites, it mentioned that it has the capability, but we don't have it available to us right now, but certainly we are exploring into it. The other, I think, practical application. So in addition to what I think we heard about how we can manage patients at the nursing home, I think we are trying to go from like really see the, and it's nationwide trend, all the ambulatory care, if outpatient visits can be or being converted from face-to-face to either telephonic or telehealth. Previously, I think the technology and abilities were available, but the interest was not there. And there was no incentive or a push to really adopt these easy to implement platforms. Now there is. So we, I think I just heard yesterday that at Penn State Health have created 5,000 accounts for various people, the clinic staff, the physicians, the over APPs. I think in the next phase, we will create the accounts for the residents and fellows. So we are into that early onboarding phase. I think simultaneously we are developing some best practices in primary care pockets and eventually to the specialties as well, because in some services it suits to have telemedicine. In other, you know, people are reluctant, but I have seen, you know, once you start to use these things, eventually, you know, the reluctance goes away and the change kind of sets in. So the other thing which we have been doing at the Penn State Health is the tele-EICU. So most of our ICU rooms, or more than half of them, have this capability. So the equipment is already installed in the rooms. So the audio and video feed is we have been doing this for a few years now. So it actually goes to like a central command center, which is staffed by intensivists and other specialists. So we are actually not only using that ability to monitor patients, but how in the middle of COVID, emergency, if somebody is in the ICU on the ventilator and the traffic is difficult and high, you can actually control the room traffic by getting that tele-ICU, really look at that feed, whatever is happening inside the room to out of the room, and or maybe if the physician is at home, they can actually review those feeds. So those are some of the initiatives. I think sky is the limit. I think that we just need to be creative. There are a lot of other options and other creative ways, and this is the good time to develop some best practices before the regulations come back.
Can I ask a simple question? What is meant by translation services, though? I'm sorry. Can someone clarify that for me?
Let me see. I interpreted if the patient, if you have a Spanish speaking or like a language translation, or was that the question? I'm sorry, I'm just trying to go to the chat window again.
Yeah, I just want to make sure I understand. I'm responding. Yeah, language barrier. Okay. Yes, and I'll just add a little bit to that. A lot of nursing homes, well, almost all nursing homes that I'm aware of previously had language and translation services, and many used iPads, etc. And so this should be no different than that. And in fact, because of those language barriers and because of the need for translation services, many already have an iPad or some kind of tablet or some device already, which then could be utilized also for the purposes of telemedicine. I can address the next question if you'd like with billing, and I'm happy to go into the billing and coding piece of this. So we've seen very significant relaxation of the billing and coding regulations, and I can try and catalog, and then we can have a more open discussion. So effectively, prior to this, you could use telemedicine, but you couldn't bill for it effectively unless a nursing home, the originating site location, was in a HRSA site, which you'd have to go onto the website. You guys already know that. You're in a rural, non-metropolitan area, okay? So that's been removed. So now it's saying, okay, you can use telemedicine. And then the second piece was, well, how often can you do telemedicine? It used to also be that the telemedicine, even in rural areas, can only be used once every 30 days. Well, that's been removed and replaced by medical necessity. Then the next piece that was addressed was, okay, can you do regulatory visits? And that took a little bit longer to repeal and change, but the answer now is yes. So admissions, readmissions, regulatory visits, those 30, 60, 90-day visits, all can be done through telemedicine. But this very specific question, I believe, even after saying all of that, I think is basically saying, well, how do I bill and code or perhaps get to the same level? And it's more challenging now, right? Because for the higher the billing and coding that you want means the longer the time it takes for the nurse to be working with you or the telepresenter. So I think that this is a meet in the middle, right? And also telephonic services are now covered as well. So the key to this, honestly, is remember your nurse or nursing staff is perhaps busier than ever, and you need to respect that. At the same time, we should be grateful, frankly, that there's any billing and coding that's allowed. And so even a small offset of this is useful. So I don't know if that addresses your point, but you're correct. It's hard to do, let's say, a comprehensive examination. You could do it, but at what cost, right? The nurse has to basically be there the whole time, and it could take a lot longer. So I just want you to keep that in mind. And I don't know if that answers the question.
Hi,
Please.
this is Dr. Kim Albert from UVA. We had a discussion about this yesterday because of the way we're trying to deploy telehealth to some of our long-term care facilities in the area. And we're using it for an e-consult service, or what leads to an e-consult service with specialists who would decide about transferring that patient to the hospital. But because the G2010 billable code that is meant to you know, as a consult code is meant to keep the patient out of the hospital, that encounter wouldn't be billable because the patient's going to the hospital. And part of what we're trying to figure out is obviously that is the necessary end state of the encounter. And so how can we kind of find a way around, but find a way to bill for a service that enhances the care of the patient without getting into the, you know, the questions of if we're preventing an unnecessary hospitalization, because I think it is a necessary hospitalization.
Let me ask a couple of questions and I think I can answer. So is the consultant going to be doing live audio and video, or is it you're sending them an email or some other asynchronous communication?
Well, I think it's going to start with a collection of, we talked about doing a store and forward, just for the purposes of not having to have a pulmonary or infectious disease doc, you know, available 24/7 to do one-on-one. And to be honest, we're still working through that. But the idea would be probably, excuse me one moment.
It's all right. We get it.
I think the hope is that there's going to be an e-consult that would be a telephonic exchange, and then there's also going to be the opportunity. So there's, in the workflow, there's kind of two routes: either e-consult, telephone exchange, consultation, or a face-to-face.
Okay. So I have a much longer talk, and the person who joined me was from a healthcare law firm, and I'm happy to share the more full slide deck. I believe that was addressed, that you can get paid for e-consults. Not only that, but both ends get paid, including in the nursing home, meaning the requester and the person who's addressing the e-consult. I can send you that and connect you to the person who basically said that, and because this was a question that's come up. The other option is, which will be at a lower rate, once again, just making sure we come full circle. If you made it synchronous, they could bill for a subsequent care nursing home consult, the 9307 through 310.
That would be great. Thank you.
I love that summer started in March, right? All the kids are home for the rest of the year.
They're weighing in too on the talk. They have questions, I'm sure. Why are you using my iPad for telehealth, Mom?
Thank you all for your contributions to that discussion. Are there other questions or comments that anyone would like to bring up? Kim, I know that you mentioned you provided a comment around training and familiarization with the equipment. Is there anything else that you wanted to add to that?
Sure. I think that it's just sort of a paradigm shift for the usual telehealth model in not, because, you know, you would have a patient come to a site, the originating site being a clinic where there is a trained telehealth nurse presenter. And in this case, we are asking certified nursing assistants, one of the 2 RNs who is on shift with over 100 patients, to, you know, take time to potentially, you know, apply a lot of PPE, go into a room, try to work a device that maybe they've never used before with gloves on. So there are some aspects of the bedside delivery of this that that we're really trying to work through in terms of, you know, what information do we need? How quickly can the person who is in the room with the patient provide it? And is it really, you know, do we need to connect with a special telehealth device, or do we really just need an iPad and be able to watch the patient breathe, see if the patient can talk, you know, through while walking, that kind of thing. Like if it's a truly acute kind of consultation, you know, it will probably look a little bit different because, you know, it doesn't, storing heart sounds or lung sounds and then waiting for someone to hear them an hour later and decide that, yes, that is something that we're concerned about. And then getting the corporate structure of the nursing homes, you know, in terms of having the LIP who is the primary care provider for that patient who may not be co-located to talk to someone at the hospital, adds in a couple extra steps. So I think that there's I think there are ways to employ it to really enhance care, but I also worry about introducing new technology into an already, more stressful and I guess I won't say dangerous time, but a time when providers are more concerned about this disease in particular, and then trying to train staff is one thing that we're trying to make as easy as possible.
I think that we completely agree with using available technologies. I'm certainly not advocating for new, because new requires the technology to be purchased, procured, distributed, trained, et cetera. And so I also was making sure, and if you guys wanted the QR code, if you took a picture with your phone and grab that, it'll open up to an algorithm. And frankly, the approach that we're taking, even though it's still under development, is really very simple sign and symptom-based management, right? It's oxygen saturation, it's temperature, it's the presence of cough, whether or not other people are already co-infected, et cetera. So less is more here. Maybe in the future we'll have the luxury of time, training, money to have more industrial approaches that are more comprehensive in nature. But I think right now I completely agree, simpler is better. This is the keep it simple, approach right now for sure.
Yeah, this is Greg Caputo from Penn State Health. I just wanted to add a little bit to that, which I so agree with, and thank Amy for an extremely useful, illustrative case, in part because while I think most, if not all of us who are on maybe at large sort of academic or other large regional centers, I'm thinking of the rural clinicians and staff at a nursing home or other extended care facility who could help provide the same type of comfort and closure that the case illustrated, with very low tech, generally speaking, low technology, low-end technology. And I think that's helpful for those of us who have access to more sophisticated technology, that the folks in the more suburban and particularly rural areas can really help benefit their patients and their families. So thank you.
Thank you for that great point on the rural environment. I'd like to ask, are there any nurses online who would want to share their frontline stories or their input on telehealth and getting comfortable with it?
So this is Rebecca Steele. I'm a clinical nurse leader, and my background is in deploying remote patient monitoring programs to health systems across the country. And I would say that there's so much power in engaging nurses right out of the gate and designing and implementing these programs, because you're going to get buy-in and people will want to use it. So I think it shouldn't be something that's overlooked in any type of program. Because the nurses really understand what the need is and where the gaps are, and are just pivotal in designing the workflows so that it doesn't create more work, but falls in line with the workflows that already exist.
And to Rebecca's point, we've been talking about even little things like if your device is specifically a telehealth delivery device and it requires updates, making sure that turning it on before patient care begins during the day shift so that the update happens, during night shift or something like that, it is something that the nursing staff is really going to be able to tell you and create time for, because the last thing you want to do is, have an LIP on the other end of a call and the machine won't work because it's updating, because they do that occasionally. So little things like that. And like I mentioned with, wearing gloves and not being able to use the touch screen, and then how to disinfect these devices without blurring the screen with a bleach wipe, that kind of thing. So there are definitely aspects of nursing care and the actual delivery of, getting to the patient that, involving the nurse is going to be critical.
The other piece, this is Rebecca again, to put my more technical hat on, through my experience, is that obviously right now time is of the essence, so we should get these technologies up and going. But in a place where there's more time to work through these programs, I think it's also really key, if you're using mobile devices, to leverage a mobile device management tool to really own and manage the technical side of the solution from end to end, so that you are decreasing as much technical issues and making the device as straightforward as possible. So for example, a mobile device management tool allows you to really just kind of control a pool of iPads. And so you can really configure each iPad so that the experience meets the need of the end user, through simply just creating a home screen that has the people to connect with, whether it's technical issues or clinical questions, because everyone knows how to turn on an iPad, right? So if you can read the background and that can kind of get you to the right person, that makes it a lot easier to kind of troubleshoot in the moment and connect people to the people who know answers to their questions around those technical issues.
Thank you for sharing that. I know that we have a lot of our nursing students online, so our nurse practitioner students. So I'm hoping that they're taking all of this to heart, and they also can get CMEs for this session. So that's awesome. Any last questions or comments before we wrap up? We have a few more minutes left.
Thanks to Dr. Handler.
Yes, Greg, I agree. Thank you.
Sure. And please consider, like I said, downloading or accessing this document. The goal would be for all of us to contribute to and make it a central repository of knowledge that we continue to update. The ownership of this is really distributed and really meant to help all. I think the introduction, we're going to be building on deprescribing next, filling out the PA Pulse video that was just released last night about in COVID. That just is going to be added to it, and then just continue to plug away at this and add content to share as much as we can. So thank you for your consideration in that.
And Stephen, before we wrap up, there's a quick question. Has CMS relaxed requirements for routine?
So they have not relaxed the requirement to do those. The regulatory visits are still needed. What they've done is they've relaxed the requirement that they need to be done face-to-face. Prior to the changes in the regulations, including like a week ago, which seems like an eternity, that you had to do those face-to-face. And now the regulatory visits, which are still required, are just required still, but can be done through other modalities.
Thank you. So I'd like to thank Stephen and Amy, Kimberly for your great insight, Greg, Rebecca, and everyone else who contributed. A few quick closing items. Reminder that you can collect CMEs for participating today. There'll be a follow-up survey sent out. Please complete one survey for every session you attend, and you can use the same link for each submission. And again, we'll be sharing all information. And finally, we hope you will join us for our next scheduled ECHO session, COVID ECHO session, which will be tomorrow, April 9th at 8 a.m. We'll be welcoming Dr. Joshi back to discuss mental health resources and preventing burnout in staff. So please continue to watch your email, and thank you again for joining us.